I want to thank the Icarus Committee for inviting me to speak. I'm Chris Huff. I'm one of the interventional cardiologists at Riverside Hospital in Columbus, Ohio, and I'm going to discuss endovascular therapy for iliofemoral DVT, a non-lytic approach. I think it's important to understand that venous clot is quite different from arterial clot. Arterial clot usually presents acutely once it wedges itself in an end artery, and therefore it's usually a smaller clot burden, and the clot is almost always acute. This is the case with MI and stroke, and even limb ischemia. The venous clot can build slowly over time, and in terms of DVT, clot can extend from the ankle all the way to the iliac system before a patient becomes symptomatic. So at the time of presentation, there is quite a large clot burden, and the clot can be of different morphologies, including some that's acute, some that's subacute, and some that may be relatively chronic. The reason that DVT is often managed with thrombolytic therapy is because most thrombectomy devices have been designed to treat smaller, more acute arterial thrombus, and the small caliber catheters used for that thrombus just aren't very effective for the treatment of large volume DVT. That is not the case with the Clot Triever thrombectomy system, which was specifically designed to treat the large burden of thrombus that we see with iliofemoral DVT. It consists of a catheter with a 16 millimeter coring element to help core thrombus from the venous wall. And then the catheter is pulled out through a 13 French sheath that has a nitinol funnel to help prevent snow plowing as the thrombus is removed through the sheath. There is no lytic therapy involved. It's very effective at removing acute, subacute, and even more chronic thrombus. Patients can be treated with a single session of therapy with procedures taking from 30 minutes to an hour. If they're straightforward, there's minimal blood loss, there's no capital equipment, and it does not require an ICU stay. So this is an inexpensive treatment. So this is an animation of the Clot Triever catheter in action. You can see the catheter is advanced past the thrombus in the iliac system. The nitinol element is exposed or unsheathed, and as the coring element is pulled through the iliac system, it cores thrombus from the venous wall, collects it in the basket behind the coring element, and it's safely removed through the 13 French venous sheath. Not surprisingly, based on its ability to remove large thrombus, patients get better. You can see based on clot registry data, in patients who have complete or near complete thrombus removal, there's a marked reduction in Volta score as well as PTS rate at 30 days. The added benefit is procedure times are short, 31 minutes. That's a benefit to a busy physician as well as for the patient who has to lay on the table. 99% of patients in this registry were treated with single session therapy, and the blood loss was minimal at 40 cc's. So let's spend a few minutes looking at a real-world case using the Clot Triever device. This was a 36-year-old female who presented with a right iliofemoral DVT that was felt to have been provoked by a recent ankle sprain. She had 2 weeks of increasing right lower extremity edema and discomfort. There was no personal history or family history of VTE. The patient's only significant past medical history was ITP with a baseline platelet count of around 40 to 50,000, as well as polycystic ovarian syndrome for which she was taking estrogen-containing hormone therapy. Her venous duplex on presentation revealed acute thrombus of the right external iliac, common femoral and femoral veins. In the ER, she was initiated on a heparin infusion, and per our protocol, her leg was elevated overnight with a plan to reassess her symptoms the next morning. The next morning, she continued to have significant pain and swelling, and therefore we elected to proceed with mechanical thrombectomy. We didn't feel she was an ideal lytic candidate based on her low platelet count. The patient was brought to the cardiac catheterization lab and placed prone on the table. We then used ultrasound and a micropuncture needle to gain access in the popliteal vein. We inserted the micro sheath and then upsized to an 8 French sheath. We then gave a heparin bolus to achieve an ACT between 250 and 300 seconds, and performed standard contrast venography through the sheath and with a multi-purpose catheter to visualize the more proximal segments. You can see that with heparin overnight, there was improvement in thrombus that was visualized on the ultrasound in the femoral vein, though her external iliac vein was still occluded. At this point, we used an 035 hydrophilic guide wire and a multi-purpose catheter to wire through the occlusion and into the IVC. We performed a quick venogram through the multi-purpose catheter to confirm we were within the IVC, and then extended the wire up into the right internal jugular vein. You need plenty of running room with the Clot Triever catheter because of the long basket that extends behind the coring element. Once in the internal jugular vein, we replaced the guide wire, or the hydrophilic guide wire, for an Amplat super stiff wire, and then we upsized our 8 French sheath to the Inari 13 French Clot Triever sheath. Next, we performed intravascular ultrasound to confirm there was no external compression on the iliac vein, which is often the cause for iliofemoral DVT. You can see based on IVUS, there's no significant thrombus in the common iliac vein, but the external iliac vein is occluded with a significant amount of thrombus. The thrombus does extend into the common femoral and the femoral veins, despite those areas looking, fairly clean by venography. The other thing that's important is there's no evidence of external compression. So though left-sided May-Thurner is more common, you can certainly have right-sided May-Thurner, but we did not visualize that on this ultrasound. So the Clot Triever sheath was advanced into the IVC past the thrombus, the coring element was unsheathed, and the catheter was pulled back through the iliofemoral system. You can see after one pull we have restored flow within the iliac system, though there's still a large degree of thrombus. This is the second pull through the iliofemoral system. You can see after that is complete, there's just a small amount of residual thrombus. With one final pull, the thrombus was gone, and this was confirmed by intravascular ultrasound. This entire procedure took about 25 minutes. As per usual, there was a mixture of acute, subacute, and chronic thrombus, again, that was easily removed by this catheter. The patient was discharged from on Eliquis. Her estrogen-containing OCP was discontinued at discharge. She had a venous duplex at 1 month that was negative for DVT. On follow-up, she had no PTS with a Villalta score of 0. She was treated for a duration of 3 months with Eliquis, and it was subsequently discontinued. Thank you.